There are things I knew in my first year of surgical practice that I never once explained to a patient sitting across from me. Not because the information wasn't important, it is. But the appointment was 12 minutes long and we were already running behind. And the thing I was paid to address was the specific symptom or test result in front of me, not the full picture of what was happening in that person's body, or what it would look like in 5 years, or what they could do right now to change it. My name is Dr. Robert Hargrove. I am 61 years old. I practiced vascular surgery for 35 years before retiring. Vascular surgery is the specialty that deals with blood vessels, the arteries and veins that form the infrastructure your entire body depends on to receive oxygen and nutrients and to clear waste. I operated on that infrastructure for the better part of 4 decades. I saw what it looks like when it fails. And what I want to do today is tell you what I wish I had said far more often, and give you an honest account of why I didn't. Let me begin with a number that I think deserves more attention than it gets. 8.5 million. That is the current estimated number of Americans over the age of 40 living with peripheral artery disease, PAD. That number climbs sharply when you focus on adults over 60. Peripheral artery disease means the arteries supplying blood to your legs, and sometimes your arms, though the legs are far more commonly affected, have been narrowed by plaque buildup to the point where blood flow is meaningfully reduced. It is a chronic, progressive condition. Left unaddressed, it worsens over time. It can be managed, it can be slowed. In the early stages, it can be substantially improved through interventions that do not require a surgeon. What I find troubling, and what I want you to understand, is that the majority of those 8.5 million people were not diagnosed on the day their disease began. The disease began years before they were diagnosed, in many cases, a decade before. It progressed quietly through stages that had recognizable signs that were either never communicated to the patient or communicated in language so vague that it created no action. I want to tell you about a patient named Helen. Helen was 70 years old when she was referred to my practice. Retired schoolteacher, composed, intelligent woman. She had been told at some point in the previous 4 years by her primary care physician that she had poor circulation. Those were the words she repeated to me when I asked what she'd been told. Poor circulation. 4 words. That was the entirety of the clinical communication she had received about a condition that had been progressively narrowing the arteries in both her legs for the better part of half a decade. She had been given a prescription for compression socks and sent home. By the time I saw Helen, she had significant bilateral peripheral artery disease. Both legs were affected. She had been walking with pain for 2 years and had been attributing it to the hip replacement she had received 18 months earlier. She had noticed that her feet were often cold, even in summer, even indoors, but had not known to connect that symptom to the same underlying cause as the pain in her legs. Nobody had told her they were connected. Nobody had told her that what she was experiencing had a name, a progression, and a treatment pathway. I cannot tell you this is exceptional. I can tell you it is common. I can tell you I have sat across from that person more times than I can count. So let me tell you what poor circulation actually means. Not as a phrase, as a medical reality. What it looks like, how it progresses, and where, at each stage, the door is still open for intervention that doesn't involve a surgical suite. There is a classification system that vascular specialists use called the Fontaine classification. It describes the stages of peripheral artery disease with clinical precision. I want to translate it for you into plain language because I believe that understanding this changes what people do. Stage 1 is the silent stage. The arteries are narrowed, blood flow is reduced, but you feel nothing. No symptoms, no pain, no obvious sign. This stage can last for years, sometimes more than a decade, and during it the disease is progressing. Plaque is accumulating, the vessel walls are becoming stiffer, the lumen is narrowing, and no alarm is sounding. The only way to detect peripheral artery disease at stage 1 is through deliberate screening. The test is called the ankle brachial index. It involves placing a blood pressure cuff on your arm and one on your ankle, measuring the pressures and comparing the ratio. It takes approximately 10 minutes. It is painless. It is inexpensive. And in the hands of someone who knows what they're looking at, it tells a great deal. Adults over 60 who have a history of smoking, who have diabetes, who have high blood pressure or high cholesterol, or who have a family history of cardiovascular disease should be receiving this test regularly. In practice, many are not. It is not part of a standard annual physical unless the physician proactively orders it. Most physicians do not proactively order it unless the patient already has symptoms. And so stage 1 progresses to stage 2 without detection in a great many people because no one was screening. Stage 2 is where symptoms begin. You start to notice pain or cramping in your legs when you walk. The location of the pain gives information about where the arterial narrowing is. Calf pain typically indicates disease in the femoral or popliteal artery. Thigh or buttock pain suggests the aortoiliac segment. The characteristic that distinguishes this pain from arthritis or muscle soreness is that it is reliably provoked by walking and reliably relieved by rest. You walk 2 blocks, your legs ache and feel heavy. You stop and stand for a few minutes, the pain fades. You walk again, it returns. This is called claudication, from the Latin word for limping, and it is as textbook a presentation as vascular medicine has. It is also, as I have observed across decades of clinical practice, extremely easy to explain away. People tell themselves they are out of shape. They tell themselves it is their knees. They tell themselves this is simply what getting older feels like. Helen told herself it was her hip for 2 years. I do not say this critically. I say it because the explanation is plausible, and because no one in a position of authority has told them otherwise. If you walked into your doctor's office at stage 2 and said, "My legs cramp when I walk and it goes away when I rest," a good physician would immediately order an ankle brachial index. But most people at stage 2 do not walk into their doctor's office with that description. They mention in passing that they have been having some leg pain, and the appointment moves on. Stage 3 is rest pain. The pain is now present even when you are not walking. It is typically worst at night, when the legs are elevated in bed and gravity is no longer helping push blood downward toward the feet. Patients at this stage frequently hang their legs over the side of the bed or sleep in a recliner, not consciously understanding why that position relieves the discomfort, but having learned through experience that it does. This is a sign that the circulation is significantly compromised. This is the stage at which most patients first enter vascular surgery practices. Stage 4 is tissue compromise. Wounds on the feet or lower legs that will not heal because the blood supply is insufficient to support tissue repair. Gangrene. And in its most advanced form, amputation as a clinical necessity. I want to be precise about why I am telling you this, not to frighten you. I am not interested in fear as a motivational tool. I am telling you this because the staging information changes behavior in a way that vague warnings do not. If you understand that leg cramping that goes away with rest is stage 2 of a diagnosable and treatable condition, not simply an artifact of age, you will call your doctor. Helen would have called her doctor. A great many people watching this would call their doctor. Now let me talk about what can actually be done, particularly at stages 1 and 2, which are the stages where the range of options is widest and where the outcomes of intervention are best. After I retired, I had dinner with a colleague I have known since residency, a cardiologist with a distinguished career and a remarkable degree of candor. I was describing this exact gap, the space between diagnosis and meaningful education that seems to exist in every specialty. The patient is told they have a condition. They are given a medication or a pair of compression socks. They are sent home. Nobody sits down and explains the progression, the options, the decision points. And he said something I have not stopped thinking about since. He said, "Robert, we don't get paid to prevent, we get paid to fix." He was not being bitter or cynical. He was being precise. The compensation structure of the medical system, what insurance reimburses, what generates revenue for a practice, what is billable versus what is not, is organized around treatment and procedures. A 15-minute educational conversation about lifestyle modification for stage 1 peripheral artery disease is not reimbursable the way a stent placement is. I understood this structure while I worked inside it. I could not fix it then. I can at least be transparent about it now. So let me tell you what the evidence actually supports for people at the earlier stages of this disease. Supervised exercise therapy is the single most evidence-supported non-surgical intervention for symptomatic peripheral artery disease. Not a general recommendation to walk more, a structured, supervised program of walking to the point of moderate claudication pain, stopping to rest, and repeating. This is done under the guidance of a physical therapist or cardiac rehab specialist 3 times per week for a minimum of 12 weeks. The mechanism, counterintuitive as it sounds, is real. Progressive ischemic conditioning promotes the development of collateral circulation. Essentially, your body begins to build alternative blood supply routes around the narrowed vessel. Endothelial function improves. Pain thresholds increase. Walking distance improves dramatically in most participants. Randomized trials have compared supervised exercise therapy to angioplasty and stenting for stage 2 PAD. The exercise group achieved comparable improvements in walking distance and quality of life at 6 months and 12 months. Comparable to an endovascular procedure. Most patients I operated on over 35 years had never been referred to a supervised exercise program. Some had been told to walk more. That is not the same thing. Dietary choices, and I have addressed specific options in other videos, have documented mechanistic effects on vascular function, endothelial nitric oxide production, and plaque progression. Smoking cessation is the most impactful single modifiable risk factor for peripheral artery disease. The data on this is unambiguous and has been for decades. Every year of continued smoking accelerates the progression of the disease in a measurable way. Every year after cessation, the trajectory begins to improve. If you smoke and you are over 60, this is the single most important thing I can say to you today. Blood pressure management, diabetes control, lipid management, these are the structural pillars that a vascular surgeon thinks about when reviewing a patient's long-term prognosis. They are also the things that primary care physicians address, usually with medication. What is less commonly discussed is the additive benefit of dietary and behavioral interventions layered on top of appropriate medication, not instead of, but on top of. A patient who is well controlled on a statin and who has also addressed specific dietary contributors to oxidative stress and inflammation is in a meaningfully different place vascularly than a patient on the statin alone. I want to spend a few minutes on deep vein thrombosis because it shares risk factors with peripheral artery disease, but is a separate condition with its own clinical picture and its own urgency. Deep vein thrombosis is a blood clot forming in a deep vein, most commonly in the calf or thigh. Under normal circumstances, it causes local swelling, pain, and warmth. The danger is when the clot, or a portion of it, breaks free and travels through the venous system to the lungs, causing a pulmonary embolism. A pulmonary embolism can be immediately life-threatening. The risk of DVT increases with age for several reasons. Blood viscosity increases. Clotting factor levels change. Venous valve function, the small valves inside your leg veins that prevent blood from pooling when you are upright, becomes less efficient. And the behaviors that provoke DVT become more common. Prolonged sitting, extended periods of immobility after illness or surgery, long-distance travel. For adults over 60, the 2-hour flight that carried negligible clotting risk at 35 carries a different profile now. This is not cause for anxiety, it is cause for awareness and simple precaution. On flights over 2 hours, get up and walk the aisle every 60 to 90 minutes. If you cannot do so, perform seated calf raises and ankle circles regularly. This activates the calf muscle pump, which is the primary mechanism your body uses to push venous blood upward against gravity when you are sitting. Drink water. Avoid alcohol, which causes dehydration and vascular changes that increase clotting risk. On flights over 4 to 6 hours, speak with your doctor about whether compression stockings are appropriate. For most adults over 60 with any vascular risk factors, they are. The warning signs of DVT are distinct enough that I want to name them clearly. Swelling in one leg, typically one leg, not both, because the clot is in a specific vessel on one side. Warmth over the calf or inner thigh. Redness or skin discoloration over the affected area. A persistent, deep ache that is different in character from typical muscle soreness and that does not improve with rest or position change. If you experience these symptoms, particularly within 24 to 72 hours after a period of prolonged sitting or immobility, this is an emergency room visit, not a call to your primary care office for an appointment next week. Pulmonary embolism can develop rapidly, and the window for anticoagulation treatment is important. I want to close with something practical, a short list of questions. because one of the things I have come to believe in the years since I retired and began thinking about all of this more clearly is that what patients most need is not more information to absorb. They have access to unlimited information. What they need is the specific, targeted questions that unlock the information from the people who are supposed to be their partners in health. If you are over 60, these are the questions to bring to your next appointment. Ask, what is my ankle brachial index and when was it last measured? If your doctor says you have never had one and you have any of the risk factors I mentioned, smoking history, diabetes, hypertension, high cholesterol, family history of heart disease, ask for it to be ordered. Ask, do any of my current symptoms, leg pain when walking, cold feet, slow healing wounds, suggest peripheral artery disease that should be evaluated? Ask, what specific lifestyle interventions, beyond general recommendations, do you suggest for my vascular health? And if the answer is eat better and walk more, ask what that means in measurable, specific terms for your situation. And if you have ever been told you have poor circulation with no further explanation, no staging, no plan, no follow-up, then I am telling you today that you deserved more than that, and you should ask for it. The warning signs were there for Helen. They were there for Frank. They were there for dozens of patients who moved through my practice across 35 years and who came to me later than they needed to because nobody had given them the language to act sooner. I have the time now to give you that language. Please share this with someone over 60 who would benefit from hearing it. And if anything I described today sounds familiar, if a symptom or a conversation with a doctor or a moment of explaining away discomfort sounds like something you recognize, please make that call. The door is still open. It is open longer than most people realize, but it is not open indefinitely.